Hi, Mike Gibson and Leslie Shaw, and we are talking about the DECIDE Registry. Leslie, talk to us a little bit about what you did and what you found.
So we have this larger DECIDE registry, about 20,000 patients. What we're still recruiting for, we're about 15,000 into it. One of the sub-studies within this was about 1,000 patients looking to evaluate the role of plaque as a guide to prevention. You know, as we all know, we struggle with keeping patients compliant, and we struggle with lowering LDL cholesterols. And so, of course, all of us think that plaque can be a great motivator for change, both on the physician side and on the patient side.
Well, it
So
was for me, Leslie. Once I had a high calcium score, then I got my scan, and now I got my LDL down to 27. So yeah, it could
that's
be a big
awesome.
movement.
Wow,
Yeah.
that's cool. And the same for every patient, I think, for most patients, I think. So what we did was kind of clever. We allowed the patient to have a CT, and then we didn't introduce the plaque until 90 days later. So all of the early decisions would have been based on what you would find, stenosis, it's right. And those decisions would have occurred. And then once we introduced the plaque analysis, we tracked what else they did to the patient. So it allows us to really isolate those decisions. And about 50% of the time, was slightly more than 50%, but it was pretty close. People changed management and important changes in management. A lot of intensification of lipid lowering therapy, as you would expect, referral to specialists, and in some cases, an addition of SGLT2s, GLP-1s, colchicine, other forms of preventive therapies. So in total, I think, and we didn't really push people to do this. We made some, guidance for how they might make changes. But what's also really cool is that the more plaque you had, the more likely you would make changes. Now, as all of us, we would say, of course, but I think saying of course and getting and seeing it as two different things, right? And so we saw that really 75% of patients with a ton of plaque also had changes in management, which is reassuring, I think, and we're going to continue to follow these patients and hopefully they'll stay on these medications.
Now,
And do
Leslie, when you say plaque, it wasn't just the narrowing. You used AI to look at what was in that narrowing, how much fatty stuff was in there,
That's
and
right. That's
risk,
right.
right?
100%. Yeah, we use the new AI-based automated plaque analysis, and a guy and our initial cut of the data looked at total plaque volume, which would obviously incorporate stenosis as well. But I think importantly that non-obstructive plaque was also in there, which we often have historically, as we all know, have ignored for the most part. But so we're now getting people to shift towards saying, not just stenosis, but plaque is important. And I think, this is just a better step forward to having more, precision-based preventive care that the patient can be more compliant with and adherent to, particularly other forms, and not just their medications, but lifestyle changes.
Yeah, a guy like me just looks at the center of the donut. I just look at, is the donut open? But
Yes.
we ignored the donut. And, when I was at University of Chicago as a medical student, my pathology professor was Seymour Glagoff. And
Yeah.
Seymour Glagoff is the guy who taught us that, the artery stays the same size inside, but the wall just gets thicker and thicker until you get to about 40% of it is plaque. Then it starts to narrow in. So, you're right, Leslie. We're often sitting on top of a lot of fat in the wall of the artery that hasn't really narrowed the artery yet, but that person's still at risk. Is that right?
100%, 100%.
Yeah.
And I think we're seeing too, just in prevention in general, this movement, towards more plaque guided care. And this is just one step. I think it's an important step, and seeing that clinicians can make those changes based upon plaque. And this is interesting because it's not the folks like you. It's not, I mean, Ron Blankstein and other colleagues of yours were involved in this, but it was certainly a number of private practice locations. So, we have a diversity of physicians that are saying, "Hey, I can't ignore this. I've got to react to this, and I've got to be proactive in initiating very intense preventive care." So it's pretty awesome to see, and I think it's a very positive side for coronary CT and the use of plaque.
For me, it changed things. My LDL was about 57 to 70 on a high dose of ezetimibe, but when I saw what was going on, I got it down to 27, like a hunter-gatherer or something with the addition of a PCSK9 inhibitor. So from my point of view, you can't be too rich, too thin, or have too low of an LDL. That's not for everybody, but that was my choice.
Well, I think more people are agreeing with you.
Yeah. Well, Leslie, thank you so much. Thanks for sharing today. Good luck at the conference.
All right, awesome. Thanks a lot.